This is She's on Call, a weekly show hosted by ENT specialist Dr. Sujana Chandrasekhar and General Surgeon Dr. Marina Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's on Call, hashtag She's on Call. Please welcome our hosts.
Good morning. I'm Dr. Sujana Chandrasekhar. I'm an ear, nose, and throat surgeon with a specialty in ears in New York City and New Jersey.
And I'm Marina Kurian. I'm a general surgeon, and I do minimally invasive surgery as well as weight loss surgery in New York City. I love when you throw in the ears part. I'm like, so people come to see you and they're like, it's my nose.
I'm like, I don't know what that is.
Not today, sir.
We have a great show today. We're going to be talking about diabetes and diet and nutrition. We have incredible guests on today. Dr. Joana Miragaya is an endocrinologist and PhD in nutrition science in Atlanta, Georgia, and Rachel Lustgarten is a dietitian and co-host of the Primary Care Medicine Show on Dr. Radio on Sirius XM, and she's based in New York City. So we have a lot to discuss with them. Marina, diabetes is a really prevalent condition, right?
So diabetes and prediabetes affect about 100 million people just in the US and over 422 million people worldwide. So it is really a disease, a common disease, and something that needs, to be addressed on a global level. And we're going to talk to our guests in a little bit about the difference between type 1 and type 2, in case people are confused, type 1 and type 2 diabetes, and what are some of the best ways to treat it, to eat, because nutrition is so critical, and also what medications that we can give for those diseases. So it'll be a great hour ahead. I'm excited to talk to both of them. And then remember for our viewers that if you like what you're hearing, or if you think someone needs to know about diabetes and nutrition, because who doesn't, share on Facebook, retweet us on Twitter, and we're also on YouTube. So you can share and tag your friends.
And on Mondays from 2 to 3, we are broadcast on WBAI 99.5 FM in New York City and WBAI.org around the world. But first, let's get to the news, Marina.
Yep. So big news, the vaccine, it's a-coming, right? So the Pfizer vaccine was just officially approved on Friday evening by the FDA. So that's really great news. And this is the Pfizer vaccine is a 2-dose vaccine, and it's being shipped. We're getting a lot of doses, but understand, like it says, like millions of doses, but then each person needs to get 2 of them. And it's quite a strategy. It is really, there's been talk about how it's the biggest logistical rollout of any national health policy and actually globally, right? It's quite a to-do to try and get it into the hands of the population. And it's already been rolled out in the UK.
Right. So the first person who got it outside of a trial, the Pfizer vaccine, was a 90-year-old woman named Margaret Keenan in England. And the second person who got it in England was a fellow named William Shakespeare, which I thought was very interesting. But of course, these are not the first 2 people to get the vaccine. The vaccine has been in exhaustive clinical trials. Thousands, tens of thousands of people have gotten the vaccine already, including the show's very dear friend, Dr. Valerie Fitzhugh, who is a pathologist at Rutgers, New Jersey Medical School, and her Twitter handle is at DRFNA. So at Dr. FNA, which stands for fine needle aspiration. But she actually did an amazing Twitter thread about her experience, particularly as an African-American woman getting the vaccine and how it felt each time. And I learned a lot just reading her thread.
Well, so if you guys want to know the thing about the vaccine trials that are still ongoing right now, you can either get the vaccine or a placebo. And the testing before and after is pretty rigorous. And then they want to follow you out for up to 2 years. And I was like, hey, I want the vaccine. Like, I understand the concept of getting the placebo so that you have a control group. But as a healthcare person, and I applaud Valerie for doing it, she doesn't know if she got the placebo or the vaccine itself. So it's interesting, and it's definitely a Twitter thread to check out. And again, as Sujana said, it's so important to include groups that represent our society. And so having African Americans and Hispanics in these studies is very important, as well as older age groups and even children. And then the Moderna vaccine is before the FDA, but we don't know when that's going to be approved. But they were already allocated, I think, over 50 million doses for the US.
Yeah, so then there's who's going to get the vaccine, right? So now we all want the vaccine. This is like somebody put on Twitter, this is like the adult version of writing your Christmas wish list to Santa, right? We just all want the vaccine.
Well,
So the rollout, the rollout in the United States is not a national strategy, it's a state by state strategy. But there are particular groups who are scheduled to get it first. And we have a little graphic from the Washington Post on this. So the first in line should be healthcare workers and nursing home residents. Second in line are going to be essential workers, teachers, and first responders. And then third in line are going to be about 89 million people with pre-existing conditions and those over 65. Now, the vaccine is approved in people age 16 or older, and we have about 250 million people age 16 or older in the United States. Over the next several weeks, we expect batches of 30,000 to 100, maybe 200,000 vaccines. Each vaccine is complete when you've had two. So you need two shots, either 3 weeks apart for Pfizer or 4 weeks apart for Moderna, to be vaccinated. So this is a long rollout. So this does not mean we forego our masks and our distancing and our hand washing.
Right, absolutely. The other thing is, for public health policy, as I said earlier, when you were saying we all want the vaccine, not everybody wants a vaccine. People want to kind of see what happens. They want other people to go first. And as I said to my friend, I'll be your huckleberry. I will get that. I will get that vaccine first and detail, what issues there are. Dr. Fauci, who's world respected, is planning on taking the vaccine in public, or so that people can see what happens and demystify sort of the process. And then, and I'm sure that other people will as well, other celebrities, etc. It's Dr. Fauci is a celebrity after all,
Absolutely. Dr. Fauci, all of the living former presidents of the United States have said they'll get the vaccine publicly. Francis Collins, who's the head of the National Institutes of Health. This is not rushed, but it has been expedited. But I think the science is real. I think you had a funny story that you found about a different vaccine.
Well, okay, so the Sputnik vaccine, I didn't know if we'd have time today, but the Sputnik is the Russian vaccine, which, we don't know a lot about, but there was a New York Post article on it, which said basically that the Russian government was like, get the vaccine, but you can't drink for 2 months because obviously that can affect your immune system. And that's going to be tough because, Russia's like fourth country in the world in terms of alcohol consumption. But they also said when you're getting the vaccine, which and this is for 42 days, which is 6 weeks, right? That you have to continue to do all the social distancing, hand washing, face masks, etc., that we've already been doing. And that's actually true of when you get the vaccine. We should just be safe. And one other reason that I thought it was interesting to put that up is because we don't know a lot about the Russian Sputnik vaccine, but we do know a lot about Moderna vaccine, the Pfizer vaccine, the Oxford vaccine as well, because of the transparency in the reporting of their data, which I think is so critical to really allaying the public's fears about, getting the vaccine and what common side effects could there be and how effective it is. And I think that is, again, one of the great things about this global outreach that we've had because of the pandemic. You know, we've been sharing so much data that there are no curtains, there's nothing to hide behind. You know, it's very
Right.
transparent.
Well, one of our viewers, Kedar Ramanathan, says, what do you think is the chance that most people who want the vaccine in the US will actually be vaccinated by June? And looking at what is being said by the current administration and the incoming administration, they expect 100 million vaccinations in the first 100 days of the Biden presidency. So, I think that we will be well on our way by June, and certainly by the end of the summer, with just about everybody vaccinated who wants a vaccine and can be vaccinated. And we really hope most people want a vaccine. But let's go on to our guests, because this is an amazing, amazing topic that you selected, Marina. And why don't you introduce our guests?
I don't know if I did select it. I think you did, but it's fine because I'm so excited. So you guys are going to hear from two wonderful experts. Rachel Lustgarten, she's a registered dietitian at the Comprehensive Weight Management Program at Weill Cornell in New York City. She's also co-host of the radio show with me, Primary Care Medicine, on Sirius XM when we're on Tuesdays from 8 to 10 a.m. And she is the yin to my yang on that show. And then Dr. Joana Miragaya, who is an endocrinologist in Atlanta, Georgia. Her PhD is in foods and nutrition, and as well, she participates in the internal medicine residency program, I believe, at Emory. So we're so excited to have you guys. Come on, welcome.
Thank you for having me and us. Good morning.
Good morning.
Good morning. Thanks for coming on. At some point in the last 6 months, Marina and my brains have fused. So maybe I thought of this idea and maybe I didn't, but it's good to fuse with a smart person. Can we talk a little bit about, and I know you're in Atlanta, Joanna, and you're in New York City, Rachel, can we talk a little bit about how things are going with COVID cases in your area? Maybe Joanna, let's start with you.
So COVID cases are rising nationwide. So it's known that nationwide the cases are rising. But want to bring it to this radio today. It's an important fact that COVID, people with diabetes are not at an increased risk from getting COVID compared to the general population, but they are definitely at an increased risk for complications or from COVID or prognosis if they do get the disease.
So that's something that we've seen, right? That we know that obesity is a risk factor once you get COVID, to have more severe form of the disease, and it can also affect your recovery. So I know, so as you said, if you have diabetes, doesn't mean you're going to catch it easier, but if you do get it, you can have a worse form of the disease or a longer recovery, or both. Joanna?
Yes, so with increased risk for hospitalizations as well. So that's why sugar control is so important, because as we know, diabetes does affect your immune system. So it decreases your immune system, so controlling your blood sugars will definitely help you for a better course of recovery as well.
And Rachel, I know that the cases, we had a huge surge, obviously, at the beginning of all of this in March, April, and May. And then we had maybe a little second wave, and certainly we're seeing a third wave. When you are counseling people who need help with dietary guidance, how are you doing it during COVID? How are you interacting with these people?
Great question, Sujana. And I feel lucky. In my practice, we had already been trialing and using telehealth platforms. So when the world shut down, when New York shut down, our offices shut down in March, for me to make the transition to just seeing my patients via telehealth and virtually was really seamless. So that was amazing. And I've been able to continue to deliver the nutrition counseling, particularly for these especially vulnerable patient populations of people suffering from prediabetes and diabetes, it was like we really never skipped a beat. So that's been really excellent.
That's wonderful. Yeah, that's great. Maybe, Joanna, can we step back and talk about the prevalent, like who gets diabetes? How many people get diabetes?
Yeah, well,
why are we talking about this?
Let's talk about type 1 and type 2. Why don't we describe the difference between those two? And then, we mentioned earlier, as you know, that about 100 million people in the US have diabetes and pre-diabetes. But can you break out what that really means and what are the different types?
Sure. So, so breaking out between type 1 and type 2, but we do know, I think that Marina, you mentioned earlier that it's around 88 million in the US Americans have pre-diabetes. It's pretty much a 1 in 3. And while diabetes, it's a number of 34 million, which is a 1 in 10 Americans with diabetes in the US. When we break down between a type 1 and a type 2, a type 1 is pretty much someone that does not produce insulin, is an autoimmune disorder, and this person will require insulin as their therapy, pretty much lifetime therapy. While a type 2, it's someone that develops some sort of insulin resistance, will require different treatments, which could be either oral medications, injectables, or even insulin.
Right. So in that graphic that we had up kind of shows that there is some overlap between the two diseases in terms of symptoms, but really the treatment is very different. If you can just kind of talk to that.
Okay. So the differences, so in terms of complications, they both carry the same complications, cardiac complications of an uncontrolled diabetes or cardiac, renal, or any organ complication of uncontrolled blood sugars. In terms of symptoms, they might vary or they might be very similar on the first stage. It all depends on how uncontrolled your blood sugars were when you compare the two of them for initial symptoms of the disease. In terms of treatment, and again, with touch base, it's just the type 1 is just completely depletion of your insulin secretion. So you do need the insulin therapy for type 1 patients. While the type 2, they can vary quite significant, but oral medications can help insulin, or there are other sources of injectable that are actually not insulin. And both of them, they do require lifestyle modifications, but also for type 2, lifestyle modifications is very, very important to decrease the insulin resistance.
And with type 1, Joanna, kids get it, adults or adolescents, late adolescents can get it. Like I remember one of my classmates in college had all the signs. She was drinking a lot, she was peeing a lot, she had lost weight. And then when she went home for like one of our breaks in college, she was diagnosed with type 1 diabetes. And there's some discussion that perhaps it's hereditary, but there's also discussion that this can come from a viral illness, right? That's how maybe kids get it. They get like an adenovirus or something. There are certain proteins in the pancreas that then the body's like, oh, this is bad protein, I'm going to attack it. And so it can be an autoimmune attack on the beta cells, which are the ones that create insulin in the pancreas.
Sure, there is. So the idea is it's not completely understood, the process on how someone can develop. We do know it's an autoimmune, and it seems that some environmental changes, such as a viral infection, can promote or induce the type 1 diabetes. But again, there's also the genetic component and several other components that are not well understood yet.
So even though type 1 is less prevalent than type 2. As Marina was saying, a lot of times this is diagnosed in children and adolescents. And I remember my very dear friend's son, suddenly, his temperament changed. He had this drinking all the time, urinating all the time, being so tired, but being so kind of frazzled. And eventually she actually made the diagnosis. Everything was chalked up to, adolescent male behavior for a while. And she made the diagnosis with a home test that she she bought at the local pharmacy. But one of the things that I realized, you know, you can study all you want in medical school, but it's really interesting when somebody personal to you has it, is that they really had to change the diet completely. And I think that's something, Rachel, it actually initially made no sense to me. They were told to buy packaged goods so they could really count the nutrients in the goods so that then they could learn how to prepare foods at home. So what kind of counseling do you give with initial diagnosis of either type 1 or type 2 diabetes?
Well, Rachel,
Yes.
that's a symposium question for you. But you know what I did?
But like, where do I start? I
wait.
love the question, and I have so many things to say about it.
I know. Well, look at this though. When you Google, first of all, I want the world to know that Google loves me. So when I ask Google something, it tells me immediately. It's so good, right? So we have a slide of, I put in best diet for diabetes, okay? Because that's what you're supposed to tell us, Rachel. So our slide shows all of these books. If we could just pop up that graphic of all the books that popped up. These are the top books that showed up. And actually, none of them are necessarily one's from the Mayo Clinic, but you could see that there's so many varieties of diets, but the underlying principles have to be pretty close, I think, to really, there have to be underlying principles in each of these diets that are similar.
Right. And I'll just add that graphic of those books, I mean, I believe those are probably the top books, but this is a tiny, tiny percentage of what is out there. Anyone who is curious about this would almost have to like throw their computer out the window after asking Dr. Google about a diet for diabetes, because they're just going to be so inundated with information. And like many things in diet and nutrition, it can be very overwhelming for people to kind of go alone. So back to Sujana's question about kind of where to start with all of this. I mean, the comment about an adolescent being diagnosed with type 1 diabetes and really having to do a diet overhaul resonates for a lot of people, because as Joana was mentioning, these patients are not creating insulin, and that the lifestyle behaviors and modifications, it's important, but they really can't treat diabetes and cure it through diet. They're going to be, in most cases, dependent on insulin. What I mostly do in my practice is help people that have been diagnosed with either pre-diabetes or type 2 diabetes. And these patients can start by making smaller changes to their diet that are going to be impactful for blood sugar control in the long run.
Right.
So, you know, we have a comment from Susan Pizanitsky. I hope I got that right. Chandrasekhar should be able to pronounce Pizanitsky, who's from Stuyvesant Town in New York City, where I grew up. So, hey, go Stuyvesant Town. And she said that she got a diagnosis as pre-diabetic and then had a lot of low-carb diet type of control. So maybe before we go to Rachel about the diet, can we talk, Joana, about what is pre-diabetes, what is diabetes, and what does hemoglobin A1C mean?
Sure.
I'm only asking the simple questions today.
So let's start with what's pre-diabetes. So pre-diabetes is it's on the step of getting diabetes. So it's when your A1C, it's between a 5.7 to a 6.4. A 6.5 and above is a diagnosis of diabetes. So a glycated
Can you just say those numbers one more time so our viewers can get them?
So it's a pre-diabetes, it's a glycated hemoglobin between a 5.7 to a 6.4. And diabetes is when the A1C is above 6.5. It's equal or above 6.5 is a diagnosis of diabetes. We also have other measurements and other diagnostic tests for pre-diabetes as well as diabetes. We have the fasting sugars that we can check on a blood drawn, as well as a glucose tolerance test, which we give sugar to the patient and we'll check blood work with glucose levels between a certain period of time. But the most widely used is the A1C. And the hemoglobin A1C, it's a glycated hemoglobin. It is the sugars will get the red blood cells have a high affinity for sugars, and they will bind so then the glucose will then bind to those red blood cells. And it will stay bound to those red blood cells for a certain period of time. And the lifespan of a red blood cell is around 4 months, which is 120 days. And that's why the A1C test is every 3 months. So we can catch that average blood sugar for the last 3 months on someone.
You know what I love about the A1C, Joanna, and I tell my patients this because, you know, I do weight loss surgery and also weight loss management, is like they can't cheat. It's not, sometimes, you know, when they come in to see me the week before, the patients are like, oh yeah, I was on my best behavior because I knew I was going to come see you. So like starting 10 days or a week ago, I've been, you know, really watching everything. And I always tell them, okay, but when we check your A1C, I'm going to know what's been going on for the past, you know, 3 to 4 months. So this is a true representation of what's actually happening in your body. And it's so cool that you're able to look at that number and kind of treat patients based off of that. It's such an exciting window into the little micro mechanisms, right? It's just, you know, it's cool. I love the A1C as a thing. And I think that patient who lost weight on her own, like Rachel, you and I both, when we do the radio show, we talk about diabetes as well. And people call in and they're like, I got that diagnosis and I totally changed my lifestyle. I started working out. I changed my diet. And you know, again, similar story to Ms. Pizhnitsky, that that her hemoglobin A1C actually went low, 4.7. She said that's pretty low, isn't it, Joanna?
Yeah, so it's pretty much back to the normal range, right? Because it's below 5.6, so it's below a 5.7. So it's not below 5.7 to a 6.4. Now, Marina, I do want to mention that like it's a 3-month average blood sugar, right? So if someone had so let's say sugars that start to rise or something that happens, you might not be able to catch if this is a short term. So sometimes having other methods of checking as well, the fasting glucose or the glucose tolerance test does help with diagnosis as well.
So what's a low carb diet? Like everyone says, oh, I'm low carb, I'm no carb, I'm this, I'm that. What does that mean? What should somebody do if they're truly trying to follow a low carb diet, Rachel?
Right.
What I ate for breakfast today. One.
And I love Susan's comment too, to even be introducing this this concept of what a low carb diet is. Also the fact that she was able to drop that A1C so significantly. I loved our graphic with that Venn diagram of type 1 and type 2. And I noticed that it spoke to, with type 2, being able to prevent through lifestyle modifications. But we should also mention that we're seeing, you know, we don't use the word, and Joanna, you can chime in on what you feel about using the word curing diabetes. But what we see in Susan's case was that she had this diagnosis of pre-diabetes. We know that diabetes is a progressive disease, so that we don't wake up one day with an A1C over 10, that this has been slowly increasing over time, but we didn't always have the means to be testing. People didn't know all of these different things. It's kind of progressing silently. Susan was so proactive in her health, and she was able to get out of that pre-diabetic range into a normal, healthy range. So whether she wants to say, I was cured of my pre-diabetes, I mean, she really did the work herself. And back to Sujana's question about what are we talking about when we say low carb diet? Well, there's no one definition of how many grams of carbohydrates a day should someone be eating to qualify for a low carb, a very low carb diet. And we don't have all the information about exactly what Susan did, although she is referencing a book that she might have used, and we can get to that in a little bit if we have time. But the first thing that people can do is start taking a look at your overall diet and what are the forms of processed carbohydrates in the diet. So when I say that, we're talking about mostly things that come out of a container, a package, a bag, chips, cookies, processed carbs like bagels and breads and things like that. We're not as concerned about whole foods that might be carb containing, like vegetables have some carbs, fruit has some carbs, beans have carbs. First order of business is let's focus on processed carbohydrates in the diet.
Right. So, one of the things that we talk about all the time is a low carb based on the processed carbs. But, there are apps that you can actually use, like I use Lose It, MyFitnessPal's another. There's actually several. I don't know, Joanna, if you have a favorite, or Rachel, there's a couple other ones that are out there that if you enter what you ate for lunch, and by the way, it's a little bit humbling and a little bit pain in the, where, because you're like, oh, I got to put this in. But sometimes when you start putting it in, you're like, someone's like, do you want dessert? And you look and you're like, no, I'm not, because I'm not putting it in here because I don't want to talk about it with my phone or my app, right? Because then they're going to come back and tell you. But the app will give you a breakdown of how many carbs you had, how much protein you had, how much fat, how many total calories you had. So that's a great way to track it if you're of the mindset that you need to, change your diet and go to something that's lower carb, especially with diabetes. The other concept that, Joanna, perhaps you can speak about and what you tell your patients about what diet to choose when they come in with the diagnosis of diabetes. But the other concept is something low glycemic index, which the slides on it and all that is just so hard to really describe what that is. So I was sort of originally, when I was talking to Sujana about it, I'm like, let's not talk about it. And then, of course, what did I just do? I said low glycemic. Okay.
You can't help yourself. It's okay.
I really can't control my own mind or my mouth, I should say.
So what is a low glycemic index? What does that mean?
I'll leave that to Rachel to start.
Sure. So I love low glycemic as a concept, and that's what I want to speak about. I don't like it as an assignment for patients to track every food that they eat and where it falls on a glycemic index. This is very laborious. This is something a dietitian could do because we're weird and nerdy like that, and we like that. But this is not for the layperson to have to go out and calculate every single glycemic load of every meal. When we say it in theory, what we're talking about is eating foods that aren't going to have a big impact on our blood sugar. So these are foods that are going to help that blood sugar stay at an even keel postprandially, after meals. So we're not getting that spike. So these are foods that are slowly digested, that are lower in carbohydrate and have perhaps some protein, some fat that can slow down the absorption of the carbohydrate. Mostly whole foods that are minimally processed. So again, the concepts of low carbohydrate and low glycemic are really not that different. The foods that I was mentioning before, fruit, vegetables, mostly vegetables as opposed to the fruit, beans, nuts, lean protein choices are excellent for diabetes. So fish, white meat, chicken, vegetarian protein sources as well, all fall into the lower glycemic category.
So thank you so much. We have people watching from all over. Cinzia Achilli is watching from Italy, so thank you for watching us. Arthur Haubenstock is watching from LA, I think, and he actually asked why children aren't getting the vaccine, and I'm just going to answer that question because it hasn't been tested in children, and the concept being that children may be transmitted to each other more readily, but adults get sicker, which is why we're starting with adults, Art. So let's see what happens with that. Avani Yadav asked us, is diabetes more common in women? And Joanna, maybe we'll ask you to answer that question.
So diabetes, the prevalence is more in the adult population as a type 2, and it's more common after the age of 20 years old. Honestly, I'm not so sure about the ratio right now. I would have to just look it up. about the ratio, but it's very prevalent in adult population for type 2 diabetes in the US.
You know, and worldwide, if you look at Southeast Asia, you know, we look at certain body mass index or level of obesity and say, okay, you have like a 20% chance of getting diabetes. In Southeast Asia, the weight, it can be in the overweight range, and we see a significant amount of diabetes. So around the world, it is different. And Joanna, also in this country, in the Hispanic population, they have a higher incidence, I believe, of type 2 diabetes.
Yes, it's a higher incidence of type 2 diabetes in Hispanic population, Hispanic Americans, Asian Americans, as well as Native Americans and African Americans compared to the non-Hispanic whites. So all those, ethnicity plays a significant role as well in the prevalence of diabetes.
You know, we want to thank our viewers. And again, if you're watching and you like what you're seeing and you want to alert your friends, you can certainly tag or retweet about our show. We are live on YouTube, Twitter, and Facebook right now. And then, of course, you can watch it again at She's on Call. And as Sujana likes to say, we can, and I like to say too, we're going to be on WBAI on Monday afternoon and WBAI.org worldwide. So you can listen again in case you're like, what did Joanna say? What did Rachel say? Probably not what Marina said. That's not what big.
And definitely not what I said.
Definitely Suju. Whatever Suju says, that's the way we run She's on Call. We're like, whatever Suju says.
It's the older sister problem in me, really.
Yeah. Exactly.
You know, I have to say, Joanna, before we get to metformin, which is very interesting to me, and other treatments, I want to say that the glucose tolerance test is disgusting. So most of us have taken it when we're pregnant, and we're eating like super healthy, drinking milk, like watching everything, blah, blah. And then they shove either like Coke syrup or jelly beans at us and draw some blood, and it's gross.
No, it was a liquid. It was like this horrible flavored liquid, right?
Oh,
I had an orange drink I had to drink.
I would have had jelly beans. Where was that? You got jelly beans?
I had 4 pregnancies, so I've been through the gamut of gross syrups and gross jelly beans. So what does the glucose tolerance test do? And what does it show us? And who do you order it on?
So you order for people that you still suspect that they have some sort of insulin resistance, despite the A1C not being completely reliable. And you also order definitely for all pregnant patients. Because you want to detect gestational diabetes and treat because of the complications related to gestational diabetes to the mother as well as the baby. So that's why the test is so important.
Can we talk a little bit about how we talked about you're definitely going to, you know, if you want to change your lifestyle and address your nutrition, you can impact the diabetes. But is there a number, like, would you say that, you know, if you lost 10% of your total body weight, like, so you weigh 180, if you lost 18 to 20 pounds, is there a way to measure whether that would significantly improve the diabetes? From what I remember in med school, it was always like, if you lose 10%, it's going to improve your blood pressure and your cholesterol, and it's going to improve diabetes about, you know, it'll drop the blood sugar X amount. So is there a percentage that you guys look at when people are when you're encouraging people to lose weight and say, listen, if you lose 20 pounds right now, this will probably put you into what we say, not diabetes cure, but diabetes remission?
Right, there is, so one of the biggest trials that we had, it was the Diabetes Prevention Program trial that looked into that and looked about lifestyle modifications and how much weight loss. So the idea you're definitely right, you're definitely right, is around 10% of your body weight for a loss to increase the risk for remission of diabetes. But also there are other factors that play a role is for how long have you had diabetes and what's your residual function of your pancreas as well. And of course, patients that already are, and we're talking about type 2 patients, but if they already are on insulin therapy, perhaps they will need more than only 10%. So it needs to be a little bit individualized as well. But the idea is around 10% of your weight.
Rachel, I want to ask you about, we talked about low carb, but there are 2 great websites that you know try to help patients. They're they're for patients and also for professionals, but about weight loss and diabetes. And that is is it diabetes? It's diabetes.org. And then my other favorite one that Rachel and I always talk about on the show is eatright.org. Right. So we're going to show you some slides of what we've tried to pull out from first diabetes.org. Rachel, if you can talk about these.
Sure.
So
wait, am I seeing the slide?
No, you're going to do it from memory.
Oh, great. All right.
My friends on the show. That's all I'm going to say.
Thank gosh. Yeah, if we could put up the first slide on food for thought, that'd be great. Thank you.
Well, I should also say, I mean, we said watch out for Dr. Google, right? For basically all things medical. But those two websites that you just mentioned, Marina, are very reputable. The American Diabetes Association website, diabetes.org, that we're looking at right now. Also the website for the Academy of Nutrition and Dietetics, which is the main organization of registered dietitians in this country. That's at eatright.org. And that's just also a little shout out for registered dietitians who can be so instrumental in helping guide patients through the process of early diagnosis for prediabetes, impaired fasting glucose, any of these kind of metabolic abnormalities that we're seeing with blood sugar, and then of course diagnosis of type 1 or type 2 diabetes. These are all great resources, and dietitians can be helpful in this way.
Right. Eating right with diabetes. That's actually from
this is from diabetes.org. And even this first slide, I'm into it. And it kind of speaks to what we were mentioning before about what is low carb. Do patients with diabetes have to avoid carbs altogether? And the answer is really no. That first bullet point highlights carbs are not one size fits all. And this is really the case. There's a huge difference between a carbohydrate that is laden with added sugar that comes out of a box versus, I keep circling back to mentioning fruit, because fruit is something that often people with diabetes are really nervous to consume. And it can be part of a healthy diet for people with this diagnosis. Eating whole fruit that is fiber containing is much different than drinking a can of, fruit flavored soda or even juiced fruit. We already said no diabetes diet. There's not just a one size fits all, and that it's really part of the big picture of healthy behavior change, lifestyle modifications, adding more healthy foods into the diet. That's what I always love to focus on with my patients, as opposed to just thinking about what are we taking away? What can't you do? Let's focus instead on what can you do? I love from this slide, making half your plate filled with vegetables and maybe a little fruit on there. This is such a positive way to frame healthy eating, to talk about you can still eat your favorite foods, make them occupy less of your plate. If it's something like, I don't know why this just came to my mind, but I'm thinking of chicken parm. I don't know, maybe because it's Sunday and like people are eating a big family lunch or a big family dinner. It's not to say you can't eat any of your favorite foods, but fill your plate with mostly green veggies, salad, cooked vegetables, baked, sauteed, all of these different things. Get filled from these lower carb, lower glycemic foods. That's going to allow a little bit of room for your favorites.
So Rachel, every Indian person I know who has type 2 diabetes no longer eats bananas. And it's like the bane of their existence that they can no longer eat a banana, because apparently we eat bananas. So
we eat mango.
Can you talk to mangoes, banana, like all the good stuff? So what do we do about, people are, as you said, nervous about fruits that are sweet. And as you said, that's different than a juice or a juice drink, which is gross. But what fruits can they eat comfortably? Not in excess, but comfortably.
Right. So this is not exclusive to an Indian population. Hispanic populations, also Latin populations that come from the islands where all these amazing tropical fruits are, right, Joanna? Like mangoes and papayas, pineapple. I mean, these are all the highest glycemic fruits, meaning these are fruits that are so sweet to the taste. They're delicious. And they have the propensity to really spike blood sugar. But we have to still take a look at what else is going on in the diet. Also, what are you eating with these foods that can help to control that spike. And also, this was mentioned on the previous slide, watch your portion size. There's a huge difference between enjoying half a banana with breakfast, let's say with a Greek yogurt, with some chopped almonds in there to give it a little flavor versus, binging on, 4 bananas in the middle of the afternoon with nothing else. So I don't know if we would have time to discuss Joanna, but maybe you could talk a little bit about, like glucose testing and kind of that continuous testing that some patients are engaged in that can give us a better sense of how sensitive are you to that banana? Can you get away with eating a banana in the morning with some other protein and fat containing food?
Can you tell that Rachel has her own show? Because she's like, let's move on from the banana.
Sorry, no, but actually, I don't want to move on from the banana because I love a banana. I mean, first of all, it comes like in its own packaging, like its own on the go packaging. Like we can't completely throw bananas to the wayside. And this is something I hear all the time from my patients, that they're getting the message that they can't eat fruit at all because of their diabetes.
I want to, Joanna, we definitely want to get to continuous glucose monitoring, but I want to pop up our slide on type 1 diabetes and then go to type 2, then we can talk about the monitoring as well. So can we just talk about this a little bit? And you can see, because type 1 is not as common as type 2 currently in this country. And if you could just talk a little bit about why. But you can see how much it costs our health system in a year, almost 15 billion per year.
Yes, it's a pretty significant cost for the system, and it's not only direct cost but also indirect cost, because you're not talking about only medical bills but also increased risk for hospitalizations, increased risk for amputations and other medical complications, but also loss of productivity, which means decreased workforce. So that's why it's such a high number. But if you look at the 15 billion, if you compare that with 2017, for the overall diabetes in the US was a 327 billion of costs with diabetes for overall for type 1 and type 2. So it's pretty high cost for diabetes in the US.
So I think we're talking about, we've talked about prevention, we've talked about eating healthy. If you are just diagnosed as normal, eating healthy if you're diagnosed as pre-diabetic or diabetic. Let's talk a bit about type 2 diabetes, which is more common. And one of the major drug interventions is metformin. So perhaps, Joanna, you can talk to us a bit about what is metformin, how do you take it, what does it do in your body to help you?
So sure, and then if you go to all the endocrine societies' recommendations, guidelines for treatment of diabetes, the American Diabetes Association, as well as other endocrine societies, they will all tell you the same. Metformin is the first-line therapy for type 2 diabetes, if there are no contraindications, of course, and we can get to that later, but usually someone that has renal dysfunction, kidney dysfunction, or some more extensive heart failure or heart issues or liver disease. But overall, it's a safe medication. You take it by mouth, and you have different forms. You have the regular or the extended release, so you might have to take twice a day or one time a day. The mechanism of action is not completely understood. We do know it works in the liver, but there are other mechanisms that is still not well understood. And what it does is will work onto the liver production of sugars, of glucose, and eventually will increase insulin sensitivity. And it's pretty much does not cause weight gain, so which is a big plus for it, because those patients are already working on their lifestyle modifications and trying to lose weight by diet and exercise. So you don't want to be adding medications that can actually induce a weight gain on those patients.
So when you say it increases insulin sensitivity, that's a good thing. So this is sort of.
Oh, we got an echo here. So this slide, you were talking about how the liver makes less insulin on metformin, right? So that's what this slide is showing. And the blood sugar is the little green dots.
Yes.
And then our last slide, I have patients that are want to be on metformin or been prescribed it, and I'm not sure who's echoing, but one of us is. But what they say is that there are a lot of side effects. So we have a slide that talks about the side effects, but most endocrinologists that I know who prescribe metformin to their patients say that there's a way to take it to prevent the ugly GI side effects. If you could just pop up that other slide on metformin, the third one that we have. Yeah.
So it can cause some mild discomfort. So it can actually cause diarrhea. It can cause flatulence, and it can be very severe in some patients. So we do know the extended release has a little bit less of side effects than the regular, but it's usually better tolerated if not taken on an empty stomach. So usually we ask the patients to take after the meal, for the main meal, so to be better tolerated on the stomach. And it tends at the beginning, we start with a lower dose and we progress as tolerated. As in, what we mean is like we titrate as the patient can tolerate the medication. And if the patient cannot tolerate, we cut down to the lower dose. So to still keep the medication as long as the patient is not having side effects, which will compromise quality of life. And we don't want that to a patient.
We're going to show you the continuous glucose monitoring. And this is one particular brand, but if we can pop up the continuous glucose monitor that Rachel was asking about. This is just one brand. We're not endorsing one versus another, but this is brought up because of the way you can actually monitor. You used to have to do a finger stick. Well, you explain it, Joana.
So we know nowadays, and then there's something that I was trying to touch a little bit, so that A1C is not the most accurate measurement for management of diabetes on the long term. It's a good for diagnosis, but later on, we actually wanted to manage this disease. So we know nowadays the timing range is the way to go to control the blood sugars and to have a better picture of what's going on with the patient. And we have several continuous glucose monitoring available in the US that will actually give you that picture. And the technology nowadays is so advanced that can transmit to your phone, it can transmit to your watch, it can just use as a receiver, as a device, but it will check your sugars every so often, and it will give you that pattern. And with that, it's a better way to see for the physician as well as the patient to see how you're responding to the treatment, what foods can increase your blood sugar, and to better manage the sugars.
We also put up this insulin pump slide. So this, I think, if I'm wrong, please correct me, monitors your sugar and then gives you insulin as you need it. Is that what's happening with these pumps, Joana?
Like game changers in diabetes care.
So those are the insulin pumps. We have some in the market that will connect to the glucose sensor, to the continuous glucose monitor, and will transmit the blood sugars to the pump. And with that, with some presets that was done by the physician as well as calculations with the pump, will deliver insulin based on the blood sugars to keep on that timing range again. So that's an excellent mechanism used nowadays. What we call some pumps will call it pretty much as an auto mode or an auto control of the blood sugars through the pump.
This is another game changer in diabetes care, type 2 diabetes care, and actually I've seen some type 1s on it as well. The GLP-1 glucagon-like peptide 1 is one of these gut hormones, and this is a drug that is a stimulant for the receptor. And I use it in weight loss actually a lot with my pre-diabetes and diabetes patients. But what we found when you put these patients on, and this drug has been around for 15 years or longer, Joana?
It has been on the market for a while. We have the newer ones that, and as you know, Marina, it got even approved for higher doses of some of them for weight loss reduction. So some of the two newer ones in the market got approved as well for a weight loss reduction. So it's a great class of drug that not only will improve diabetes by increasing your satiety and making you lose weight, but also we know nowadays that there are several cardiorenal benefits of those medications. What I mean by cardiorenal is it does help with your heart and your kidneys with some people that already have complications of the diabetes in the heart or the kidneys. So those new drugs of medications as well as other oral medications carry those benefits for some patients that already have complications.
And the GLP-1s, I'm just going to name some names. It's like Byetta, Bydureon, the other, there's liraglutide, which is Victoza, and the higher dose, which we talked about for weight loss, is called Saxenda. And then the newest one on the market is semaglutide, which comes as a pill and also is available as a shot. And they, I've talked to other endocrinologists, and we've talked about, right, Rachel, on our show, like, sure, start the metformin, but then also take a GLP-1 agonist, because it's really going to help and maximize the weight loss and improve the A1C. And we love that. There was one other thing that we wanted to talk about because we're running out of time. And Rachel, go. Intermittent fasting and keto diet. Good for diabetics or not?
In our time left, I'm going to say, if you're newly diagnosed and you're looking to make some healthy changes, I would say don't latch on to these more extreme approaches. What we really want for our patients is to make changes to their diet and lifestyle that are going to be lasting, that are going to stay with them, so that they're going to be able to see those results, see that 3-month blood sugar average from the A1C go down and then continue to go down, to see that weight go down and continue to go down. What we sometimes see with these approaches that are a little more fad diety or much more extreme or rigorous is that people stick with it for a certain amount of time and then aren't able to stay with it in the long term. And for clinicians working in this space, Joanna, you can chime in, that can be really frustrating, both for the clinician, but also for the patient. So we want people to have results and keep those results.
Yes. There's a nephrologist, we are talking to Dr. Jason Fung, who's been an advocate of this whole concept of intermittent fasting, where you don't eat, the most common form is that you only eat over 8 hours, so from 11 to 7 or 12 to 8. That's what Rachel calls the New York intermittent fast, right?
New York, yep. 12 to 8. People want to push it like 1 to 9.
Yeah.
My patients, I'm like, no.
Think what's happening in Spain. They're like, we're going to do it from 3 to 1 a.m. So like,
very Euro.
Yeah. So intermittent fasting. So the website, I always forget, Dr. Jason Fung is a nephrologist who's actually put out some great videos. It's a great website. And it is, dietdoctor.com. Is that what he changed it?
Yeah, I think he's been listening to you, Marina.
Yeah, because we've had him on our radio show, and it was always like some weird website, like I am blah blah blah, and I was like, no good. But intermittent fasting is actually, Joanna, what are your thoughts on it? Because I'm sure your patients have come to you and said, hey, can I do this? Because normally you worry about people dropping their blood sugar, but this seems to be something that, if done correctly under the guidance of a nutritionist and or doctor, it can actually result in not a low blood sugar, but you can actually stay, more euglycemic is what it's called.
Right. I'm not trying to be very quick and fast because I know we're running short of time, but Rachel is definitely right. We don't want to be going to the extremes of any diet as well, because the goal is not only to lose it, but being able to maintain. When you go to those extreme diets, it's usually hard to maintain those diets long term. And eventually it's going to be like almost a yo-yo effect. But we do know the intermittent fasting. There was an article published last year that talks about that improved the insulin resistance and decreased the weight, improved the glycemic control, and then decreased blood pressure as well as cholesterol levels, decreased inflammatory markers, and improved the diabetes as well. So it has some benefits, but again, it's something that needs to be tightly discussed with your physician as well as your dietitian to see if you fit on that plan, because it needs to be very individualized depending on the comorbidities that the patient might have as well.
Well, we're running out of time. I want to thank you so much. Rachel Lustgarten, clinical dietitian at the Weill Cornell Comprehensive Weight Management Program. You'd think I could say that like that because we say it every week. And also,
it's all good.
Thank you so much. Both their Twitter handles are on the screen. And Dr. Miragaya is an endocrinologist in Atlanta. And Suju, you want to?
Yeah, thank you guys so much. Next week, which is our last show of 2020, will be on epidemiology and emergency medicine, and we'll be having Dr. Teresa Chappell, who is an epidemiologist and public health geek, who's working on COVID-19 and racial disparities in that disease, as well as maternal morbidity, and Dr. Lauren Shawn, who is an emergency department physician and toxicologist, also fighting for equity in healthcare. We started our show 6 months ago with COVID, and we're going to end this year with a full COVID episode. So please join us. And thank you so much to our producers, without whom we could not make this happen. Have a great week, everybody.
Bye-bye.